Thank you so much. Well, I've got the privilege of welcoming an old friend, Nebraska Cancer and Nebraska Oncology Society, back with us. Dr. Eric Sherman is going to give us an update on head and neck cancer. He is a medical oncologist who is an associate professor at Memorial Sloan Kettering Cancer Center in the head and neck medical oncology section. His primary clinical and research focus is on thyroid cancers and squamous cell carcinomas of the head and neck. He also has an interest in diagnosing and treating less common cancers of the head and neck, such as sinonasal undifferentiated carcinomas and salivary gland tumors. Much of his research focuses on targeted therapy in thyroid cancers. He's currently an investigator and principal investigator on multiple studies in head and neck cancer, both at Memorial Sloan Kettering Cancer Center as well as nationally. He serves as on the steering committee for the radiation therapy oncology group. So welcome, Eric. We're thrilled to have you.
Thank you very much. Hi, everyone. I'm Eric Sherman. I really appreciate being invited back here. I love coming here for this meeting, and it's great also for me to be able to go through the slides and spend a little more time even with each of the different studies that exist. All I'd ask is, like, in the future, if I could go before Vincent, because the lung cancer data was really wonderful, and and it makes probably what we do and everything else look a lot worse in terms of how we're moving forward. Let's see. So these are my disclosures. This is the outline today, and the outline is a little bit different than I've usually done in the past, in the sense that usually we talk about something about thyroid cancer or salivary gland tumors or even skin cancers. There really wasn't a lot outside of head and neck squamous cell carcinoma and nasopharynx that really came out at ASCO this year. And a lot of this stuff is more of not practice changing, although there's been a few studies that are practice changing. A lot of the stuff is sort of things that are coming around the corner that I thought are important to bring up because I think they're going to be pretty important in the future. So I'm going to start with head and neck squamous cell carcinoma, first talking about locally advanced, then go to metastatic disease, then we'll talk about nasopharynx cancer, which is very interesting in what's going on in that area. So locally advanced, Barbara Burton has presented the long-term follow for ECOG 3311, and 3311 is a very much quotable study that has existed out there. This was a study in P16 positive oropharynx tumors that were going to undergo TORS or transoral surgery, and really looked at 3 different groups for risk adjustment altogether. It's important to know this is not comparing things to chemoradiation, and we really can't do that from study to study. But it's really looking at these situations with surgery. The groups that are looking at is one is this low risk group. So these are people with T1, T2, N0, N1. And just to be clear, that part was not randomized. They made the decision that everyone after surgery would just be getting observation. The other group, the high risk, so positive margins, positive extracapsular extension beyond a millimeter, 5 or more lymph nodes. Everyone there got post-op chemoradiation. And so even though we have those 2 groups that are being looked at, those were not randomized. There was a decision made beforehand how these groups would be treated. The only group that was really being randomized was this intermediate group in between these 2. And they're being randomized from 50 gray to 60 gray. So try and see, going down by 10 gray of radiation in the post-op setting, do you have any benefit? And you could always question how much, how important is really that, looking down at that just 10 gray. But it was at least trying to ask this question in this setting. And part of the reason is the primary outcome for this was actually feasibility. And it's hard to really think about that's what this whole study was really about, was can we do studies in the TORS section of head and neck cancer. But you want to know, could this be done in a prospective multi-institutional study? The second primary objective was looking at this question about 50 to 60 gray. Is there any benefit to the 50 gray? Realizing that this is a small study, so this is not supposed to be practice changing. This is supposed to be hypothesis generating. The outcomes were actually interesting as they were updated. And the reason is looking at arm A. So look at arm A and look at arm B. And the thing about arm B is that arm B looks definitely not worse, and if anything, a touch better than arm A. Why that's important is that arm A should be the best risk group people. Those are the T1, T2s, N0, N1 patients. So that group should automatically, no matter what we do, should have the best PFS and the best OS. And it was interesting that that's not what we end up seeing with this. The other thing is they did look the difference between arm B and arm C. And what it sort of suggests early on is that 50 gray versus 60 gray, there doesn't seem to be a difference. It's interesting that arm B, which is the 50 gray arm, looks a little bit better. So it's sort of a little surprised about it, but you look at somewhat equal between the two things. This was the other interesting thing came out results, and I would really focus on that middle thing, the pack years. Why that's important is that when Kian presented some of the early data that first showed that HPV positive, P16 positive tumors do better than everyone else, than those that are negative. One of the things that came out in their analysis was that if you had a 10-pack year smoking history or greater, you did worse as an HPV positive patient. Not as bad as HPV negative, but this was considered to be a different subset. And based on that early data, every single study ends up, stratifying for this factor. This is one of the first really big study suggests that there really may be no difference in terms of smoking history, at least in a group where the primary treatment is surgery. So it really may be that having a more than a pack year history, as long as the tumor is P16 and HPV positive, really is not that important. And we just don't know the answer to it. But it was very different than some of the earlier data. So this is that first group, that arm A that talked about that really didn't seem to do it. You thought it would do better than it did. And the reason it didn't do as well was because of the N1 group, not the N0 group. So if you're N0, you basically, no one had a recurrence. So that group did extremely well. But the N1 group, you actually see recurrences happen about 15%. And the reason why that's important is that for a long time, and a long time means still now, in the guidelines, is based on retrospective data done in both Texas and in Florida. Tumors that are T1, N1, and T2, N1, the recommendation is single modality treatment, either radiation alone, or you can see what they're doing in this group, surgery alone. And this really suggests that group probably should be maybe thinking about getting chemo and radiation because it's not doing that great. And this is probably one of the few prospective studies that sort of looked at this, although you could argue it wasn't a radiation, it was the single modality was surgery. The other thing that comes out is that thing on the bottom, when the recurrences happen. You see the majority of the recurrences happen after 40 months. A lot of our studies where we're trying to decrease dose intensity, we were looking at outcomes at 2 years and 3 years, and that may not be long enough in the HPV population to look at. And we really should be looking longer to really understand what the true outcomes for these patients are and the benefits. The other problem that also was shown in the study is that about 30% of people were not found to be eligible for the study. So that they're put on the study and then later on found out to be eligible. And that's a large number. And when you see how those patients do, it does seem to be maybe a little bit worse than the other population. So there may be a very much of a bias when you look at absolute numbers in this. And I think that's always been a little bit of a problem, is that a lot of people have taken ECOG 3311 as this is how we should be doing things. And these are the standard numbers out there. But there's some other biases that are involved with it. So in conclusion with this, one, the primary objective of the study is feasibility. And I think that's one thing that Dr. Burtness really didn't push what she should have, is that if this study was shown that we can do studies in the tourist area, why haven't we done more of this? 3311 really was set up as a first step in how we do treatment, or how we do studies in this area. And it's unfortunate that we really haven't done more. And at least in our center, there's a lot of times that we'll see 3311 quoted without the understanding that this is really not a definitive study. The other thing is the arm A about the good group doing badly. I think the issue seems to be N1 disease, and it really does question how the guidelines are set up for N1 disease, and that this group really does do worse than I think people initially expect. And the last thing is that a lot of people were ineligible, which does actually make us wonder about the absolute numbers at the end and whether we need to take those numbers with a grain of salt. I know I spent a lot of time on that because I found that very interesting study, and there's been a lot of practice changing with it. The rest I'll go through a little bit faster, some of the interesting things that are starting to come out. So the next one is a study done in China looking at neoadjuvant I can't pronounce it, sintilimab and platinum doublet in patients who are going to undergo tours for HPV positive disease. So basically, this is a PD-1 drug. They're doing it with cisplatin and nab-paclitaxel, and then you will go for tours. Single arm study in patients with stage T2 and 4, sorry, T2 to T4 and 0 to N3 disease. Their definition of a major response is that there's less than 10% viable tumors, and if there's 0%, it's a complete response. And what they saw when they went to tours is that 96% of people had at least a major response, and 68% had a complete response. 36% of people had pathologic lymph nodes present, and the question always exists is like how many would we really expect? Like how did this change things? So pretty decent results with it. The reason why I brought this study up, and I think it's important, is that the prior year, we actually had about 2 or 3 studies looking at this neoadjuvant space, whether it's for HPV positive disease, HPV negative disease. They're all using immunotherapy combinations. And they're really seeing great responses. So the question is, can this play a role in how we manage patients? Can we do less surgery, so less morbid surgery? Or are we going to end up having better outcomes in the end, which we don't know yet? But this is, I think, a way where the field is going. The put out there is that there is one randomized study of pembrolizumab versus placebo. It's just 2 doses of pembro prior to surgery that Merck ran, and the belief is that study actually is going to be presented at ESMO in a few months. So we may have some early ideas whether using immunotherapy as a neoadjuvant, as a single agent, has any benefit, but that one's going to be a little bit tricky to figure out because they only use it without any combination and only with 2 cycles. But what we do need to figure out in the long term is what survival, et cetera. So a lot of phase 2 studies have been shown. I think it's going to be time for us to go to more than phase 3, almost independent of what the Merck study shows. The next thing is looking at protons versus normal IMRT or electrons for treatment of oropharyngeal carcinoma. And this was presented by Steve Frank from MD Anderson, and it was part of a consortium of many different academic centers around. Whoever had a proton machine was interested in this. And this was what looks like a very simple randomized study, IMRT versus protons, 70 gray in patients, stratified by P16 status, restation afterwards, just how we normally treat the patients. The primary outcome being progression-free survival at 3 years, and this has been a non-inferiority study. So trying to show that protons is not any worse than IMRT, and then also looking at other outcomes such as overall survival, treatment-related malnutrition. So in some ways, it seems like this is a nice, straightforward study to really sort of finally maybe answer the question about proton therapy. The problem is that it wasn't a very homogeneous population that was being looked at. They allowed induction chemotherapy, and basically any regimen could be used. You did not have to use induction chemotherapy, and a total about 12 to 14%. So not a lot of people got it, but some people got it and it wasn't really controlled for. You also could use any chemotherapy regimen. So you could use carboplatin, you could use cisplatin, you could use carbo-5-FU, you could use cetuximab. 20 different regimens were actually used in this study, and that also wasn't controlled for. So you're end up looking at a very heterogeneous population altogether. The last thing is that it required insurance approval after randomization. So it wasn't like people came in knowing they could get protons or IMRT, and then they got randomized. After they got randomized, they then looked to see if insurance would approve it. If insurance didn't approve it, you couldn't get protons, which is a strange thing to do. Like, to have a study of standard drug A, study drug B, but if you don't get approved for B, then, even though you've already been randomized, you don't get anything. 18 people who were randomized to protons actually just dropped out of the study. 38 had their insurance denied and got IMRT at that time. And what makes it a little bit more even complicated is that then they analyzed it with intention to treat. So a very strange study that way. When you looked at the results, when you initially look at it, you say, well, at the end of the day, protons looks like, it doesn't look any worse than IMRT because you're really focusing on this section. This is a 7-year section. When you really look at how many people were have been censored early on, so we don't know what this data is going to be, and you look at 3 years, you actually don't see too much of a difference with maybe a little bit further, a little bit more benefit in the IMRT arm. And so to say that this really hit the non-inferiority at that early stage is hard to say. And I think there's going to have to be more follow-up with it. PEG tube dependence was also greater than in the IMRT arm, but there is also a bias involved with that. So in the United States, as far as I know, only one proton machine is actually connected to the inpatient hospital setting, and that's the one at Penn. So if you're going to get a PEG tube placed in the middle of treatment, it requires being admitted for, we all know, 4 to 7 days. And that 4 to 7 days, you often can't keep getting your protons. So or your radiation if you're on proton. IMRT, not a big deal. So the question is, could there be a bias in when someone was getting a PEG tube in place or not? So this doesn't really give us that information. So the conclusion is that this is a really heterogeneous population studied. Non-inferior margins way too large than anything we would normally want to use. Like, using a 1.5 hazard ratio really doesn't make a lot of sense. Usually we're okay if we're off maybe by 5% or 10%, but to be off by that much as part of analysis, I'm surprised it got through a lot of research council evaluations, and that too many patients did not get the study because because of insurance issues. So when I originally looked at this, I was like going, this is a really not a great study. I'm not sure this answers the question, but then you sort of realize why the study was done. The idea of the study is that people who want proton machines want to be able to get insurance approved, and the only way to do that is to have a study like this out there. I think that's going to get it so people can now get protons. People who have proton machines believe protons work better. My feeling of having seeing patients who are on protons is that it does seem to be less toxic, but unfortunately, I don't think we have now still a great answer in this population. Is protons really any better than IMRT? This next one, I think actually is really practice changing. So of all the studies that came out, this was a study that when I saw the title, I was most interested in. And at least in our DMT, this question has come up so often. And I was even fortunate because after this study came up, it came up again with a patient. So this really, I think, does answer a question that we've been really wanting to know about. So this is a study in patients with stage 3, 4A, 4B disease who had a high risk group, okay? And I'll talk about in the next slide where the high risk groups are. But they completed curative therapy. They were not able to get further surgery or further radiation. And it's felt that the estimated recurrence risk was could be at least 40 to 50%. So I think a lot of these are people that we probably see in our practice. And your people are then randomized to either get placebo or pembrolizumab. So the question is, in this high risk group that you can't do anything more surgically, you can't do anything more with radiation, is it, do you want to, is it worth giving them immunotherapy to lead to like a better outcome? In terms of examples of high risk, one is they had high risk nodal disease or the radiation was interrupted. So something went on that made them in a population that we expect should do worse. And there's about 10 patients for that. 37 patients had salvage surgery and we're still having positive margins. So we got chemo radiation for larynx cancer, didn't work. They had total laryngectomy. You still saw cancer at those margins, but they just finished radiation. So it doesn't make sense to do more radiation at that point. They had some indeterminate lesions, which I'm glad was not included, like a little spot or two on the chest CT scan. Oligometastatic disease that were treated definitely. So someone actually probably, so this was really 4C disease. So a solitary met, maybe in the lung or in a rib, and that got SBRT. Microscopic residual disease for patients. And then a lot of them, which are probably, I'm not sure how it's a great group to include, are people who have multiple occurrences or multiple second primaries. And the second primaries, I'm not sure how, if that's a true benefit, something that is a great group to look at. When you look at this, PFS looks wonderful. So, Vincent had, which I gotta start putting on my slides, that truck that goes through those curves. I mean, that's what tells you what's real, what's not. And when you look at PFS, it goes through that curve. Overall survival, I mean, you couldn't even put a snake, through that curve or a worm. Those are the exact same. And that's the thing, is that at the end of the day, what you really want to know is overall survival going to be better or worse. And overall survival is not really being affected. So, and that probably has to do with the fact that if you get pembrol first or you get it second, it's going to be the exact same situation. So high-risk groups were heterogeneous and some of them were quite small. So that's like a downside for the study. And while PFS was improved, which is the primary thing, there's no benefit for overall survival. And that means the timing of pembrol doesn't make a difference. It does make a little bit of a difference because if you do pembrol early on when you don't know whether it's working or not, you're going to lead to more toxicities or IO toxicities. So it really sort of pushes the idea it's probably much better to wait later and then treat than to treat early on, both for a cost issue as well as a toxicity issue for patients. So at least to me, this is, the first time we've had evidence that when you have those high-risk people with no evidence of disease on scans, it really doesn't make sense, I think, to add pembrol or add immunotherapy. And, that's what's always been asked of us. It's like, someone comes in with a super high risk, should we start them on PD-1? And I think this really sort of says, for the first time, some data that there's not a benefit. While before we would say there's no data, we really shouldn't do it. Although there's always arguments from surgery and from radiation about it. So I'm going to now switch over to metastatic disease. So this was an antibody, an ADC to EGFR that was presented with immunotherapy. So this drug, Puco, I'm going to call it, is a recombinant humanized PD-1 inhibitor that's been, is approved in China in 2022. So it's a PD-1 drug that's already been established. And then you looked at it and combined with this EGFR ADC, MRG-003. It's a phase 1 study, and then you had an expansion cohort in head and neck and nasopharynx cancer. I'll let you know you have to be EGFR positive, in nasopharynx. So it's not like a nasopharynx that wasn't already stained for EGFR positivity. And very small study, but nasopharynx cancer, you're seeing close to 80% response rate, and almost everyone has some type of disease control. So really showing very high activity. And just so everyone knows, PD-1 as a single agent really has a more of a response rate of 25%. So there's something about the combination that, at least in this small study, looks better. And head and neck squamous cell, you're seeing 60%, which actually we're going to talk about is actually what we're almost always seeing at this point in time. And that brings, and I'm going to talk about this in combination with this study. So this is another one, which I'm going to call PETO because I also can't pronounce the name with it, with pembrol and first line treatment, recurrent metastatic head and neck cancer. This is also just a phase 2 study. PETO is a bispecific antibody. It targets EGFR and LGR5. LGR5 is a receptor in the Wnt signaling pathway. And this does cause an ADCC, so similar to what you see with cetuximab. As monotherapy, peto's already been looked at in the second plus line of therapy, and it's shown a very good response rate, 37%, median overall survival, 11.5 months, which not in the first line, but in the second or past is really, really quite good. It doesn't say it works independent of whether someone got cetuximab or another EGFR inhibitor first or not. In that study, like you could not have EGFR directed therapy. The one problem with it is their definition of efficacy is that you have to be evaluable for at least 2 cycles of treatment or 1 post-baseline scan, unless you had early death or progression of disease. So it's not really clear whether people were excluded early on, and that would change responses. So it was a strange definition to have there. It was actually asked. It did not seem like we got like a straight answer altogether. But the overall response rate is 67%. It includes 3 unconfirmed responses, but still 67% with the combination. Interestingly, in the P16 group, 3 of 4 people responded. P16 negative, 13 and 20 responded, 65%. This worked almost just as well whether your CPS score was 1 to 19 or your CPS score was greater than 20. So really a very good combination. The reason why I bring up both these studies together is the year prior, we actually had data from BCA 101. So that's another EGFR targeting bispecific antibody with PD-1 and showed excellent results in HPV negative population. We've had 2 phase 2 studies with cetuximab and PD-1 that have also shown really great activity as well. So there's something going on with using EGFR inhibitors with immunotherapy in HPV negative population. So these studies really suggest that there may be a real benefit using this combination together. The only thing that makes the pedo data a little bit unique is that they saw activity in P16 positive disease, which is not clear that we see in any of the with the other combinations. I always will put the caveat to that is that there's only 4 people that they looked at, so it wasn't like they were looking at like 50, but 3 or 4 at least suggest there may be something present. The other caveat that exists is that it was P16 positive. Why do I say that? So for years, we've been using P16 as a surrogate for HPV disease. There's been some recent data showing that P16 positive HPV negative disease does not do very well, and that you really need to stay in pods for HPV. And actually, we've changed our whole practice at Memorial for the last like a year and a half, where it's now required that we have to stain every tumor for HPV. We can't depend just on P16 alone status. So it may not be like a true HPV group. But right now, there's going to be multiple phase 3 studies that are going to be using these EGFR plus PD-1 combinations versus PD-1 alone. Most of them will be in HPV negative. My guess is that at least one will be in HPV positive as well. But right now, this is where the field of head and neck cancer is going for metastatic disease. And I don't think it's going to be that long before we see something, because each of these studies, they look so promising compared to what you see PD-1 alone. The caveat I would bring in is that these other studies are really looking at response rate. Response rate with immunotherapy may not be as that important. It may be more what is the PFS and overall survival, like I say, like at a 1 year or 2 year mark, because of that tail that's there. So we don't know, whether this is a true truly going to be better, but they really do look pretty impressive, all these studies. This is the second study that changes practice. And this was one study that I looked at, like what the model was. I knew 100% what the answer was going to be, and I was completely wrong with this. So this is a study done in India in people with PS2 and 3. In the second plus line of therapy, they've had to have you had to be platinum refractory. They had to at least been given immunotherapy or at least had a chance to get it. Sometimes there's reasons why people couldn't get it, and if they weren't going to get immunotherapy, they're also eligible for it. They have to have good organ function. And the question that really existed is that you have these people with a PS2 and 3. These are people who are like almost always excluded from clinical studies. They're always considered, bad actors. And, is it better to treat these patients with chemo, or is it better to do best supportive care? The outcome, 6 months overall survival, which is a good outcome to look at. They had a physician choice of what to do. This one regimen with methotrexate, celecoxib, and erlotinib has been well studied in India. A regimen that probably costs very little money. It's all oral. Pretty good results compared to it's what you would expect to get from almost any other chemotherapy regimen. So a reasonable regimen to use. The other choice was using docetaxel. So every time we look at these low PS studies, the low PS people never seem to do well with treatment. Unless you had a very chemo sensitive disease. Yeah, if you have like a germ cell, testicular cancer, yeah, you do well with a low PS still. But for in general, we usually don't. So, you look at this design, and I would have put my house down that the answer would have been best supportive care was going to look as good or maybe even better. It wasn't the case. 6 months overall survival was significantly better if you got treatment versus if you got supportive care. Went from 9% to over 50%. So there is no question, and this is true dump truck area. This is a dump truck on top of a dump truck. You see like gigantic changes in these curves. So this is really sort of telling us that patients can get with a 4PS can get chemo. There are some caveats to this. So one, to me, this is one of the closest things to change in practice. That you have a person comes with PS2, 3, and you say you really should be on hospice. You've been on multiple lines of treatment. We don't have a standard option at this time. The problem is that only 15% of the people had ECOG PS3, and those are the ones that are always most clear that you shouldn't be treating. So we're losing a little bit of the patients who we really think should go on hospice in this. So this was mostly still a PS2 study. And I could say with PS2 studies is that if you're anything like our group and and what I've learned from mentors over the years, if you come in and you have a borderline 1-2 and you have a PS1 study, 0-1 study, you become a PS1. If you have either that or you're a PS3, you don't get any treatment. If you have a PS2 study, a lot of these PS1s, borderlines, will now be jumped up to PS2. So I don't know if that was some things that happened. The other thing is that if to get onto the study, your physician had to feel that you could get some type of systemic therapy. So it was almost like a self-selected group. And a lot of times, what we really think the benefit of performance status is not what performance status is, but that performance status is really the gestalt of the physician treating the patient. That when we treat our patients, we sort of have an idea who would benefit from more therapy and who really needs to go on hospice. And that comes into how we grade these things. So it could be there's a very big selection bias to it. But at the same time, if you're going absolutely how you grade PS2 or PS things, I think now this is good evidence that we should continue giving treatment for PS2 patients if we really think that they're eligible to get more systemic therapy. So now I'm going to go to the most confusing part of head and neck cancer, and that's nasopharynx cancer. So just as its background, for which I'm sure everyone knows, nasopharynx cancer is a cancer that often is driven by EBV, but not always. In the US, we do see a subset that are HPV driven or not driven by virus at all. It is very, very common in Southeast Asia. It is not common in the United States at all. So we don't see a lot of nasopharynx cancer here. In New York, we probably see more than a lot of other places because of the population there in New York City. But at the same time, even then, we don't see anything close to what they see everywhere else. In South, at least in Southeast Asia. So you talk to people who are one of the major centers in Hong Kong or in China, and they'll see like 1,000 cases per year. While you're lucky at most places you'll see 5 to 10 cases. So it's a very much geography driven disease. So most of these randomized studies come from Southeast Asia. It's rare that we get a randomized study in the US. The first one is this looking at this drug Endostar with concurrent chemoradiation. This was a little bit of an older study in the sense that now most of us will give either neoadjuvant chemotherapy or adjuvant chemotherapy with concurrent chemoradiation. This was done where there was still some belief that chemoradiation alone should be standard, and it was just chemoradiation alone versus chemoradiation plus Endostar. Endostar is an antiangiogenic agent. It reduces hypoxia by inhibiting angiogenesis, and it was a reasonable thing to look at with radiation and chemotherapy. When you look at the PFS on this, you see a benefit here, and try if you can remember the numbers, it's great because it goes along with some of the things that we'll talk about. But 3-year PFS was 75.1% in the concurrent standard arm. In when concurrent plus Endostar, it goes up to 84.8%. So you see this benefit in PFS in a curable population. When you look at overall survival, it's still there. I mean, you could argue whether, it's getting closer, but there's a benefit that's still present. And in the curative setting, an absolute survival benefit of 4% is good enough that, we would use as standard of care. So you're seeing overall survival benefit with this. And the interesting thing with it is when you look at it is, the first thing I always look at is the censoring marks. If all the censoring marks are too early, it's too early for them to report the study. Here, all the censoring marks really are after 40 months. So they're reporting the study at a decent time. The next one, and I'm going through these a little bit quickly, we'll talk about exactly because there's a lot of this nasopharynx stuff coming out, and trying to put this together is not the easiest thing. So, June Ma did a study of adjuvant PD-1 in local regional advanced cancer, and June Ma is one of the more respected investigators in nasopharynx cancer in China. And this was a simple study. This is, he took people now with what is truly nowadays probably the standard way we treat cisplatin gem neoadjuvant, followed by chemoradiation, and then randomize people to adjuvant PD-1 or not adjuvant PD-1. And he says like straight out that his rationale for doing it this way was that there was so much data in head and neck cancer that when you put PD-1 with radiation, that looked worse almost than anything else. That it almost looks like a detriment, but definitely no benefit. That it didn't make sense to look at PD-1 with radiation. And what he showed was his a PFS, or sorry, event-free survival, which is actually the more appropriate way of looking at it, not PFS, in this curative setting. Is there's a benefit with the PD-1, and it goes from 77.3% up to 86.9%. When you look at overall survival, the benefit is not there yet. However, this one, they haven't had enough events to know if there's going to be an overall survival benefit or not. So right now, it's still not practice changing in the sense that we don't know if overall survival is really going to look better. It seems to be starting to get a little bit of a trend that way, but at the same time, they have not come close to having enough events to say anything specific about it. There's one other study that came out at ASCO as well. That was with immunotherapy, this time used in both the induction or neoadjuvant setting as well as the adjuvant setting. They only presented in terms of response rate so far, but that was also positive. So we have three nasopharynx studies that were presented at ASCO, big randomized studies, all of these being positive. In last year, we had three other studies. One looking at adjuvant cisplatin 5F, GEM versus 5FU. The other one looking at immunotherapy, this time in the induction arm, the concurrent arm, and the adjuvant arm. And then those both came back positive. While the middle one says there's no difference. That was the whole point of it, is that was a strange one looking at an old study looking at chemo followed by radiation versus concurrent chemo radiation. There's been multiple studies showing that chemotherapy is much more valuable with radiation than either in neoadjuvant or adjuvant setting. And there, they actually showed no difference. If anything, the induction arm is doing better. So really sort of almost a surprise with it. And when you look at these studies, the one thing is when you look at like the standard arms with it, you can see on the top 71.5%, to 83%. The ones I want to really focus on. Let me go back for this. When you look at like the first one, which is supposed to be like the true standard of induction chemo followed by chemo rads, the standard arm is 77%. This one is supposed to be using an arm that's supposed to be inferior to induction through a randomized study, has also the same thing as 75%. When you go into these other studies, it seems like a lot of the standard arms are still going at 75%, despite moving forward with everything. You have this sort of the same thing in 2022. The EndoStar was a different study, and that was my mistake that I left that one on it. But one showing a no risk, a low risk population, that no difference was basically a positive study in a way, showing there's no benefit to adding chemo to radiation. An EGFR study with concurrent chemo radiation that actually ended up being positive, although a lot of us don't see a lot of activity with just pure EGFR inhibitors. And then one cisgem plus or minus immunotherapy also being positive and being a plenary session. And we're getting more and more of these big studies coming from Southeast Asia. They're all positive. They're all gigantic studies, and they're coming in like 3 or 4 at a time each year. So the question exists is, one, what do we actually do with all of this information? And we don't really know, because one, there's a lot of stuff that mixes up everything. Like, do you use a VEGF agent or an EGFR agent or immunotherapy or nothing with chemo and radiation, or do you not even use chemo with radiation? And do you use neoadjuvant or do you not use neoadjuvant therapy? Should you use PD-1 up front in neoadjuvant in the beginning? You use PD-1 right afterwards. And a lot of these studies almost go against each other in a way, trying to figure out where we should be doing everything. The other issue is that statistically, we shouldn't be seeing this many positive studies. So they're all being done in Southeast Asia. We can't replicate the studies outside of Southeast Asia. So we just don't know, one, are these really good studies and are they really accurate? Two, we don't know if they match the same population. So it's the same thing with every country out there, is that we always sort of repeat things because an American and European population can, even with an EBV positive disease, may respond differently than the population of Southeast Asia. So we have all these studies right now, and we really just don't know what to do with everything. So there's been a significant number of positive randomized studies in nasopharynx cancer from China over the past few years. It is difficult to catch up enough with them to figure out what is the optimal way to really treat locally advanced nasopharynx cancer. And we're not sure what we can trust, what we can't trust, and we can't figure out how to put this all together. And so that's going to be like a major thing that we have to figure out over the next few years. Because my guess is there'll be 3 more positive studies again next year, 3 more after that, and we're just trying to figure out what to do with this information. And I don't know what we're going to be able to do. The only thing that's going to be nice is that it's going to be Energy 001 is going to report out eventually. And now it's probably the first study that used both a population from Southeast Asia and a population from the US. The reason why that's important is that's probably the first study where we're actually going to be able to compare whether that population, and they all have to be EBV positive in the blood. So it's going to be a homogeneous population from looking at it, and it'll be interesting to see, do those populations do the same? Okay, do both respond to chemoradiation equally? Do all respond to adjuvant therapy equally? So at least at that point, we're going to have an idea, or the populations at least, something we could both look at. So that's really it with head and neck cancer. Like I said, not as much practice changing as we saw in lung cancer and but at the same time, there are a few things that will change our practice. And the good thing is there are a number of things coming out that we really think will change practice. And it's probably, most of them are probably 3 or 4 years away, but at least there are ways that I think we're going to move forward in a very positive way. So thank you.
Do we have any questions for Dr.
Thank you for your call. I have I don't know if the answer to the question, but there is, clinical trial methodology report for the neoadjuvant surgical
Yes.
questions that we're starting asking. Conventional wisdom is that you got to do the same surgery. The question is, are people doing less surgery now? That's a relevant question to ask. How do you study less surgery? Because it's, how do you even quantify that? And analysis and considering less surgery, I think it's got to be a high volume center, and so how do you study it?
So that's actually one of the studies we're doing over at MSK. So we have this neoadjuvant regimen, hard oral cavity to surgery, and then we're trying to see, does it alter surgery? And I'll let you know, they're doing the same thing in thyroid cancer, led by Greg Randolph at MGH. And what they're trying to do is, people have to stay up front, surgeons have to stay up front, including an independent surgeon. What is the surgery that they would do based on what we see radiographically and what's reported, noted on examination, and then figure out when a person goes into surgery, you allow the surgeon to do it based on what they see, both on imaging and what they see when they go in. And, the problems with that are twofold. One, if you're involved with the study, your tendency would be say it's going to be a worse surgery beforehand because you've got better results that way. And two, exactly what Bernie is pointing out there is that it's going to depend on the experience of the surgeon, how they make those adjustments during the surgery. And they're going to adjust, differently. Someone who sees 2 oral cavity cancer cases a year is going to act differently than someone who sees the surgery on 300 per year. So it's going to be hard to try to figure it out, but that's how people are trying to move forward with it, with the idea that you have to say something up front, and then you have to use high volume experience places with it. I do think ECOG 3311 tried doing, some other ways where they certify people. And so they try to get it so everyone is doing like tours with a specific standard, and they require that standard for you to get through it. I don't think that's going to be easy to do for these neoadjuvant studies, but something where you try to get as best you can. You have to have a certain number of cases. And that, I think, could be the best that we're going to be able to do. But yeah, even at these high volume places, it's different. One surgeon is different than another surgeon.
The other question saying about in oropharynx cancer, the potential difference between P16 positive HPV positive versus P16 positive HPV negative, that you guys standardly are testing both at Memorial now. Are you changing your standard of care based on that? So you're treating the P16 positive HPV negative patients differently?
So the change in standard is not a true change in standard of care. It's a change in clinical trial eligibility. So we won't put someone on an HPV study unless we know they're HPV positive. While before, when we were doing all these dose de-escalation studies, all you had to do was be P16 positive, and then you could get on the study. Now we're requiring is P16 and HPV for any type of clinical study. Right now, we don't treat HPV disease any differently than we do HPV negative. Yeah, I'm thinking, I don't think there's any place like right now we try to do the exact same for each one, but it's more the clinical study setting that we make the changes.
We have any other questions?
Thanks, Eric. In the study that you showed in the high-risk population adjuvant underlying, those PFS positive but OS negative. Is there any thought that moving that to the neoadjuvant setting, IO, and
Yeah.
the second done, is the thought that that would actually lead to better outcomes following trend of melanoma, with the two data suggesting that neoadjuvant IO is actually the right road, so it's sort of the trend.
So there has been it started with the neoadjuvant study from the University of Washington in St. Louis, where they're really doing more, I think, to see as a window of opportunity study, but they were giving 2 doses of PD-1 and then had surgery. And they actually showed a pretty good response rate. So they actually went to a randomized phase 3 study where people are randomized to either receive 2 doses of pembrolizumab followed by surgery versus no immunotherapy, and and then you go right to surgery. There's an adjuvant component that's involved with it as well. That study's been completed, and we actually think it's going to be presented at ESMO this year. So we're hoping we're going to find out from ESMO whether there is a real benefit or not with just using just immunotherapy for 2 treatments. Where we're seeing like those really high response rates are using immunotherapy combinations in the neoadjuvant setting. And there has been a lot of talk about using these different regimens prior to surgery. And then the question that exists, if we design that type of study, what regimen do we use, since there's been a lot that's been looked at? Second thing is exactly what Bernie brought up is, you look at outcomes, you're looking at outcomes of change of surgery, which is really difficult to figure out. You allow a change of surgery because a change in surgery for oral cavity tumor is such a big change in morbidity that you almost want to have something like that. And then the question actually that we're asking, and also Memorial, besides change of surgeries, can we actually omit radiation therapy afterwards? What's pretty impressive is that almost all these studies, you're seeing like really great outcomes in terms of PFS and overall survival as well. And does this lead to an overall survival benefit? And we don't know that. But like I said, we have to get to a randomized study to actually answer it, because all these single arm studies look fantastic. But we have to figure out, is that truly leading to benefit or not? The pembrolizumab one that hopefully be at ESMO, I think we'll hopefully first answer it. If it's a positive study, it changes practice. And now all these randomized studies become very easy because we have an arm to randomize to. If that becomes negative, I don't think it's going to take away neoadjuvant treatment, because it was only 2 cycles of pembrolizumab before surgery. And I think the one thing that we see with a lot of the neoadjuvant studies in various different diseases is that response rate actually does make a difference. And we know single arm or single agent PD-1 or pembro is what, 25% response rate. But you add chemo or add EGFR inhibitors, and all of a sudden suddenly you get 65% responses, with a lot more being complete responses. So PFS.
No, that's
No, they're going hopefully they'll actually answer, because that's the next important question is, like, in breast cancer, PAT-CR can be used as a surrogate. And if you could use a surrogate for predicting overall survival, that makes our life 1,000 times easier, because now we don't need to do these long studies looking at long follow-up. Right now, we don't have any proof that PAT-CR is it. So even if that pembro study comes back negative, if it's able to show that PAT-CR is a predictor, then it becomes even easier to do these studies. But right now, that's going to be a secondary outcome, and they'll have to take a look to see how it correlates. The other question, well, they'll have to look at overall survival, and it answers the same question that we saw in the adjuvant study, that you just get pembro later. So is PFS really that important? Or is it, should we really be looking at overall survival as what's important?
there any,
Okay, well, thank you so much, Dr. Sherman, for sharing all of that valuable information with us. For our next segment, we do want to thank our industry partners once again and encourage you to visit their exhibits while we go into our mid-morning break. Break snacks are in the exhibit hall, so feel free to stop by and refresh your drinks and grab some food.